This is the coronal CT of a patient who has been diagnosed to have a recurrent right-sided inverted papilloma. The previous papilloma uh, before the prior surgery was occupying the entire maxillary sinus, following which the patient was subsequently operated for endoscopic medial maxillectomy using Denker's approach. And now, after 2 years of surgery, he has presented with a recurrence of the inverted papilloma, which mostly is seen in the CT and the contrast MRI as a heterogeneous enhancing lesion, which is based mostly in the frontal recess on the right side. So, the attachment on the lamina papyracea and just the entry into the frontal sinus on the right side, which seems to be a small hypoplastic frontal sinus, as well as the anterior ethmoidal cavity. The sphenoid appears to be free. The septum also appears to be free in this patient, and the possible sites of attachment could be either the lamina or the skull base, and most importantly, the frontal recess and the entry inside the frontal sinus. Now, this is what you see. You've seen that the medial maxillectomy cavity is clearly visible, and here what we are doing is we are using a coblation bond to define both our boundaries and to expose bone at the frontal, at the beak region or the frontal process of the maxilla high up to the roof of nose to completely expose the bone for drilling, because we need to remove this sample. Our attempt would be to take off this sample in a en bloc fashion, though in case we are unable to do so to find the site of attachment, we might remove it in a progressive piecemeal fashion or something called a multi-block progressive resection. So once we have defined our boundaries on the right side nasal cavity, we already can see the floor of the orbit and the medial maxillectomy cavity. So what we do is, once we have exposed clear bone or normal bone around the pathologic process, that is inverted papilloma, we initiate drilling onto the normal bone so that we can start moving progressively towards the lesion and being very sure that we are not omitting any part of the lesion behind. Now we see here we are using drilling as well as subsequent coblation, and a combination of these two modalities to be able to completely resect this lesion. We are also trying to identify if we can find the opening of the frontal sinus to see if that is indeed filled with any fluid or purulent secretions, or there is actual tumor inside the rudimentary hypoplastic frontal sinus on this side. Our goal is not to violate skull base, so we would stop at the approximate location of the olfactory neuron. Our dissection generally would be more anterior to it, and though we are not using any surgical navigation in this patient, it is an option that can be exercised, particularly for the newer teams operating these kind of patients, because one could have loss of landmarks. So you see how we have removed all the mucoperiosteum, ablated it as far superiorly much anterior to the approximate location of the frontal recess and frontal sinus, all the way to the septum, to create a draft 2B kind of situation. You want to drill the entire bone from the lamina papyracea to the septum to achieve clearance of this lesion. So we are progressively drilling the frontal process of maxilla, the frontonasal process, and coabulating in between to expose bone, and to keep drilling it so that we sort of in a centripetal way we come around the actual neoplastic lesion, because a concern here is that in case there is any gross dysplasia in this lesion, or maybe a carcinoma in situ kind of situation, then we could be sure that we have done an oncologic resection and not just picking tumor on multiple sides and engaging in random drilling. So you see, we are constantly trying to navigate or locate the frontal sinus, and that is not easy given the fact that this is a hypoplastic or a very small frontal sinus. It's not a widely pneumatized one, and if it is indeed filled by the tumor, you possibly will not be able to enter inside the frontal sinus as compared to when there is just full of secretions or mucopus. You see, as of now, we are still drilling and taking our time to drill around the lesion. We have still not violated the actual papillomatous pathology. And now you see, once we have located the beak here, we are using a curved articulated punch to get us access inside the frontal sinus proper, which would then become our anterior boundary of excising this lesion. So the articulated punch gives us articulating clear bone and then progressively resecting it, thus obviating any fear of actually violating skull base while using a drill here. So as we keep and give us some space, and then to engage our drill progressively to enlarge it in all directions, anteriorly, laterally, up to the skin, and of course medially we would do that till our nasal septum. Once you see that, it becomes progressively easier while we drill and locate our frontal sinus we would move around the other boundaries, which are essentially the medial and the posterior ones. The laterally being lamina papyracea, which anteriorly we have any voids exposed, the drilling process. So one needs to be patient in this part of the surgery and not drill randomly here and there, because that would get most people astray, and you would lose a sense of landmarks and perspective. So we are still taking our time to create the anterior boundary of our resection. And apart from the anterior boundary of resection, it is also imperative that whatever the frontal sinus is, it must be clearly opened for any irrigation and for remucosalization of this region, because if one does not open this region adequately and even removes tumor, this could lead to a very refractory and bad kind of frontal sinusitis or mucocele formation, which would create a new set of complications and problems. You can see here the choana, the medial maxillectomy cavity, the bunch of papillomas there. And now you see how we have sort of defined our anterior boundary, a very small limited frontal sinus, which we have sort of just partly opened, and we would continue to open it more definitively using in between both our articulated bone punches as well as the drilling process. Now, articulated bone punches are a wonderful tool, and they come in various angles and sizes. So, in an ideal situation, one must have had access to all different sizes and angles for doing this step comfortably. But if that is not so, if that is not possible, and one is in a resource limited setting, having a 3 or 3.5 millimeter punch on a 70-degree or a 60-degree articulated punch is good enough, and that should be the choice as compared to the very steep angled ones, which although look good but are more difficult to use. We are using here a coarse diamond, which has been used previously as well, and that is why it's taking a little time. But one can use a cutting burr. Normally, we generally avoid a cutting burr here because not so much as a skull base, but there is a real risk of puncturing the skin unnecessarily, because there's not much bone between the skin and the frontal nasal process. As you see here now, there's some purulent secretions which are now being drained once we have opened the frontal sinus and the small frontal sinus proper. So those secretions and that mucopurulent discharge can be drained. And then we see that, with a olive tipped frontal sinus suction, we are navigating the erstwhile frontal sinus space. And you see here that, that's this frontal sinus is very small. It's almost rudimentary with no space. But even here, we need to be very, very sure to remove every bit of mucosa and diseased tissue here, to be not leaving anything here, because then a recurrence here becomes a huge problem. Now you see our navigator, our coagulation probe goes on to the lamina papyracea, and by first completely demucosalizing the anterior part of the mucosa and the periosteum over the lamina papyracea anteriorly where there is no tumor, and then progressively we will take our dissection again in a centripetal way posteriorly to be able to progressively get this specimen, tumor specimen, out in if it permits, in a single block, or at least in a large block, because large blocks are easier to to be evaluated by the pathologist, and any evidence of dysplasia or malignancy changes are far better appreciated in a larger block as compared to small shreds of tissue, which may or may not be representative in terms of a definitive final histopathology specimen. As you see here, we are constantly coagulating progressively backwards, trying to completely bare the bone of the lamina papyracea, all the way back to the sphenoid sinus, from the anterior to the posterior ethmoids, so that we are very, very certain that no mucosa or no periosteum has been left behind while removing this tissue. And as you also see, the bulk of the tissue does cause some impairment to our vision posteriorly, because it keeps falling onto the coagulation wand because of its suction. So one way is to continue and persist, or sometimes the other way is also to remove a big part of it, and then to just focus on whatever posterior portion of this tumor that is left, which can be tackled separately. So as you see, most of it has been removed, and that's how it is. That now the portion of it attached to the septum is now being cleared, and once that is so, along with the remnants of the middle turbinate, this would be resected as one complete portion of tissue that will be submitted for histopathology. And then once that is done, we will put our attention to the rest of the bone that is there on the frontal recess and the ethmoid cavity, while managing any amount of periosteum as well as possible disease bone. Once that has been done, we are using a cranial true cut for definitely resecting the portion of the middle turbinate that we want to send as a part of the tumor specimen and sample, not separately. And as you see, that has been removed. Now what we are doing is just using the microdivider on the posterior most aspect of the attachment of this tissue. At some places, it may not be possible to even analyze if the posterior most tissue is actually the papilloma, or it is just a scar tissue or a polyp tissue. But for whatever it's worth, it's best to assume all this is diseased and to completely remove it and not leave anything behind. You can also see some purulence in the posterior ethmoid cavity, which has to be again cleared. In a sort of a semi-oncology kind of a procedure for a benign or a pre-malignant lesion, one should follow oncological principles and not think of functional aspects of this surgery, because tumor resection is paramount, and with margins, it is very important to avoid future recurrences, which are notorious in this particular pathology. You can see how the inferior part of the ethmoid cavity is almost completely clean and just has some scar and polyp tissue and no actual papilloma disease, which is limited to the superior part of the ethmoid cavity as well as the frontal recess region, which is has been cleared. And now our goal would be, once all cells are open, to be able to conclusively ablate and maybe drill whatever amount of diseased periosteum or bone that we can find here. So you can see how there's some soft tissue which appears to be the periosteum, or this bone that is still there in the frontal sinus, the frontal recess region, which has to be excised. This also appears to be the region of the supraorbital recess of the ethmoid. Now you see we're using a coablator to completely ablate this tissue, and what you would like in the end would be to have a lot of bare bone hair, which we could then progressively attempt to mucosalize or epithelize it with the use of ample amount of irrigation for a prolonged period in the post-operative times. You see here how we are taking all the time to completely bare the bone, ablate all portions of even suspected disease mucoperiosteum, right from the lamina papyracea to the skull base, the ethmoidal roof, and to the superior portion of the septum, and not leave any shreds of tissue here. So one has to be clear in not leaving behind any disease, because even a millimeter of actual neoplastic disease left here could lead to recurrences. And as we know, the recurrences in inverted papillomas, every subsequent recurrence has a slightly higher chance of possible conversion into a malignancy, which is unfortunate given the fact that at the outset these are benign lesions, and if aggressively resected can avoid the possibilities of malignancy in these patients. So you see here, most of our procedure is done here, and a lot of bare bone is exposed. Most of it, which was considered disease, has been ablated clearly, and this is a upward looking view with a 70-degree endoscope camera onto the skull base. We are seeing the floor of the orbit, the septum, the roof part, the sphenoid sinus on the medial to this middle turbinate, and that completes the surgery.